of resistance. And they're added in there, but the values are very small. And it's affectionately known as the T model. It's a very old classic model of lung impedance. People have done other things as well to try and build on that. So this model, for instance, in the 90s was introduced, keeping the airways. This is the formula representation of a circuit. The airway component, the resistance and the inertive part, is very similar to this one here. But the tissues have been replaced by something a bit more sophisticated, because no circuit component, it's not a circuit component, but it is very much an empirical description of how this scientist observed the tissues to behave, which is basically that the tissues have a resistive component, but also an elastic component, but they seem to change in the same. They seem to have the same dependence on frequency, and that's how he tried to take that into account. So as you can see, you try and model it and introduce a mathematical term in order to explain the data. And what you do with these models is that you then fit them to the data, and essentially then you can get parameters describing the resistance of the airways, the inertance of the airways, the elasticity of the tissues, and then that gives you something to then compare with disease or with day-to-day monitoring. There are other models. I probably won't go too much into detail given time, so I'll just gloss over. They vary in sophistication and use as well. You sort of run. The problem with working in a field like in medicine is that no matter how complex and sophisticated your models become, you ultimately are faced with the challenge of how to make it understandable to people. And if people don't understand it, they're not going to use it. And that's why spirometry is so popular, because it's easy to understand. People can relate to it very well. They can see your flow, they can see your volume, they can think about it. And it's very hard to get people to understand resistance and inertance and compliance. So while these are very much used in research, they haven't really been adopted in a clinical setting yet, and they might be some way off still to be adopted. Okay, so then, but force oscillation technique is something that has been increasingly used. At the Woolcock we use it a lot, and we've also demonstrated relevance to respiratory disease. So in asthma, for instance, we know that there's greater airway resistance in asthma because the airways are narrower, because the airways are inflamed. They've changed their structure because of constant insults. And what's more, also a key characteristic of asthma is that not only is airway resistance increased, you can actually reverse that. You can reverse that increase temporarily by giving short-acting drugs, by giving Ventolin, for instance. That's actually a definition of asthma, that it's reversible. And you can measure this using forced oscillation technique. It shows that airway resistance is increased or decreased. In kids who are born premature, for instance, we've shown that they tend to have a high resonant frequency. I haven't really talked about resonant frequency at all. But it's higher in kids who used to be born premature and have a chronic lung disease associated with that prematurity. They also have a greater stiffness in their lungs. Chronic obstructive pulmonary disease is another example. It's a very common, it affects about I think 1/5 of males over the age of 65, and it's primarily driven by smoking. And we can show in COPD that you have greater airway resistance. This is irreversible, unlike asthma. And there is also, at the same time, a greater reactance or stiffness in the respiratory system. So I think I will, actually I'll mention this one slide and I will have a break. I don't have, the reason I'm mentioning it is because I wanted to talk in detail about ventilation heterogeneity, but I think in the interest of time we're not going to be able to spend too much time on it, but it's just, as I said, another way of measuring the lung function of the function of the lungs. And a commonly used test to measure ventilation is multiple breath washout, which is a method where you get the person to breathe either an inert gas that's not usually present in the lungs, and this could be something like helium or sulfur hexafluoride, and it basically acts as a marker gas. You then try and trace the gas as it becomes as it's breathed out of the lungs, and you can deduce different things about you can have various measures depending on this maneuver. You can measure, well, first of all, you can measure lung volume because I think it's Charles' law. I can't remember which physical law it is, but if you know the concentration and you know the volume before and after the maneuver, then you can deduce what the volumes are by the principle of conservation of mass. But more importantly, more to the point, you can measure how long it takes for, or specifically how many lung volume, how much, well, how efficient are the lungs at clearing this foreign gas from the lungs totally. So you can, so as you can see, this person's breathing SF6, the sulfur hexafluoride, and then with every breath, there's less and less SF6 coming out of his or her lungs, and you can do various things to that curve, and that's where engineers come in. Again, you can either try and fit a curve, or you can calculate the total amount of volume that's expelled, or and you can also go more sophisticated than that, and this goes beyond the scope of this talk, but you can actually try and model what the shape of each of that breath could be, and make from that deduce how uneven ventilation is, and I won't go into that at all today. But I'll have a pause there before I talk about the next bit, because that's pretty intensive for an hour, I think. Okay. Any questions? Should we say 2 o'clock or something? Yeah, I was worried about going over time.
No worries.
Yeah.
That's about the level of. This one is millimeter. So what is this?
It's a piezoelectric.
So it's
So it converts sound into
So it's actually do this at low frequency.
high.
Why is not?
Because the point is to measure. So if it was in your flow tank, it wouldn't be. You need a So it's sampled here.
Okay.
So there's a gas, and then the gas analyzer has a pump that draws a certain amount of gas into.
So actually, it's another type of sensor, right?
Yeah, yeah. It
what
it,
kind
it differs depending on what gas you're using. So if you're using there are different ways of doing it. So a carbon dioxide sensor, for instance, works on infrared
Yep.
principles. Whereas anything else like a nitrogen, if you're using nitrogen as your gas, or if you're using something like SO16, you would use, there are things called chemiluminescence analyzers. Those are a different breed again. Or you can also use a mass spectrometer. That's also another way to analyze gas components, which is very similar to what you use in chemistry.
So basically, if the gas is different, so we should change the gas analyzers, right?
Yes.
Can we replace only one sensor to detect all kinds of gas?
You could, and that's what a mass spectrometer does. So a mass spectrometer will actually be able to calculate molar masses, and from that, knowing it will, from that you know what gases of what molar mass is being detected.
Sorry, could you write down
Molar mass?
what is that sensor?
A mass spectrometer.
Mask. Okay.
Yeah.
And
You could, but sorry.
did you really think about can we put this sensor in the lung? I mean, in the body, because that's more accurate, and you don't need these equipments.
Yeah. Okay. So if you put the sensor in the body.
But it's focused on which material can be used, right?
I guess people shy away from that because, well, all this is a technological limitation, so a lot of us don't think about it. We think about the physics first and then the technology comes later, I guess.
Okay.
But no, the answer to that is I don't know of any systems where the gas sensor is in the body.
Okay. Maybe we can make a progress of that.
You could think about that?
Yeah. Okay. Great.
All
Thanks.
Right. Hi.
Hi, I find this one's quite interesting, but I don't get what's the purpose for the washout, like of the lung.
Well, a disease that I didn't really have time to go into this, but lungs that in disease, people are less able to expel a foreign gas from the lungs because their ventilation is there are various reasons for this. It's either because it could be something like your areas are narrower because of disease, or the elasticity of your lung has changed to a certain in such a way that when you're exhaling, you have narrowing of the airways very close to where the tissues are, and so that prevents gas from being able to escape.
Okay.
Then the fact that this can also occur differently depending on which branch of the lung, that also will affect how efficiently you can empty the gas. So it's a way of measuring how efficient your breathing is, if you think about it.
So normally for health people, if you like take one breath out, like is that 100% of the
No, there will always be a finite value. So this curve will always have a slope. It will never be a step function.
But this just for one input, right? If it's continually supplier, then it will be.
No, so you breathe in the gas,
Yeah.
and then you breathe in until the gas reaches a plateau, which means you can't breathe anymore. It's reached equilibrium. And basically what happens is you switch the gas off.
Okay.
Sorry, so when you switch the gas off, then you measure how well the person can get rid of the gas.
So actually, this is just one breath out, like.
No, this is one breath, 2 breaths, 3 breaths, 4 breaths, 5 breaths, 6 breaths.
Okay, you still take in, out, in, out.
Yes, but now you're breathing normal air.
Okay.
Yeah, I didn't mention it because there was just no time.
Fun. This is quite interesting. So, is that a time scale or?
It is the time scale. Yes, this is time, and this is flow in terms of liters per second, and this is the concentration of the gas.
So eventually, the gas in your lung will be exchanged, like 100% replaced by the other fresh air.
That's right.
Okay.
That's right.
So it's not taking just in like one breath.
No.
So that's for the normal people.
That's right. well, I don't remember where from what is, but what I was trying to say was normal people will have a curve. They won't be a step function. You don't get rid of the gas immediately. But in disease, this will become slower.
Okay.
Yeah.
Okay. So even I try my best to breathe out, it won't be like.
Well, you won't be able to clear it because it's just physics. You can't clear it immediately.
Because you know the yoga lesson, like they ask you to breathe out for 20 seconds.
Yeah.
You like just try to breathe out as much as possible.
Okay.
I was wondering if that can work.
Okay. All right.
Okay, thank you.
Okay, that's okay. So I've got 10 slides left. If you'll bear with me. Okay. The next part of what I'm going to talk about is more is stuff that I'm doing more relevant to what I'm doing now over at the Woolcott. So, and it's a little bit different. It's less about components and electronics and more about signal analysis. So, as I've shown you many different ways to measure lung function so far, but when I was overseas and dealing with a research, working in a research lab, the main question that they were interested in there is that, okay, so you've got all these ways to measure lung function, but what's also interesting to doctors is that when they see a patient, they know that intuitively they need to take, they know if they look at the patient's lung function today, they can't look at that in exclusion of everything else. They've got to try and relate this somehow to how they've behaved in the past. A value of 2 liters, an FEV1 of 2.7 liters today doesn't mean anything if you don't have anything to compare it against. And you know, there are very crude ways to do this. You can just look at how you can just simply compare 2 numbers before. But in a lot of drug trials, people do peak flow. People do measure peak flows on an everyday basis. They keep a diary of their symptoms, and they also make a lung function measurement every single day. But no one knows how to make use of this data. They collect them, but there's bound to be some information in how lung function changes on a day-to-day basis, and no one's ever looked at it. So how the research problem then becomes, how do you then go about quantifying? Are there any patterns in how lung function changes over time, and can you make this information useful or apply it clinically? So that was the focus of my work for the past 5 years. And you can have a look here at some of these peak flow diaries that I was talking about. This was taken from a mild to moderate asthmatic, and this was taken from a severe asthmatic. This is collected twice daily over a period of about, I think, 6 months. And as you can see, the traces are quite different. I mean, to start with, the severe asthmatic has a lot more, spans a lot more values. That it's much more unstable looking. But there's no way, people don't know how to quantify it, basically, and that's where an engineering methods would come in. So one of the methods that have been played around, that people started using them to look at cardiac data, and now they're just starting to use it on lung function data, is a method known as detrended fluctuation analyses. And all that is so you might be familiar with what fractals are. So a fractal is something that looks similar regardless of what scale of magnification you look at it. And that's a very, it's a geometric object. But signals can also display, for fractality, if you like. And what I mean by that is that if you take a window over, here's a signal, a time series, if you like to call it. So basically, in this case, in this example, it's heart rate plotted over time, but you can apply it equally to lung function over time. If you take a time window of observation and try and quantify the statistical properties of that signal, in the case of this analysis, you take the root mean square error of, and that gives you an idea of how much variation, if you like, exists in that window. And then you try and you blow up that window, or rather you take a larger time window and you calculate that statistical, the same property, the same root mean square error, and then you do it again and again and again. Essentially you'll find that the root mean square error scales with the window size, as you would expect, but for a signal that's random, you have a certain expectation of that relationship, but as you but that slope has the ability to change. You can get steeper slopes, and that actually corresponds to because this is a log-log graph. You start to see that there is a power law relationship. The relationship between the root mean square error and the window size follows a power law, and this is all very dry, but what was more interesting later on was that the slope of that relationship was found to, the idea behind the analysis is if you get a slope that's greater than 0.5, 0.5 corresponds to a signal that's completely random. If you have a signal that has a slope of greater than 0.5, then you have a strong relationship between variability at the short time window and variability at the long time window, and so there's a structure to the signal, if you like, that's very different to what you expect from a statistically random signal. That's basically what it is. And using these analyses, people have applied that to breathing in infants and found that the slope was greater than 0.5, and and they also change depending on sleep stages in the infants. And we still don't know why that should be the case. We don't know why breathing is non-random. And people have posited maybe it's a reflection of the control mechanisms behind breathing. Maybe it's a measure of memory because time points are related, or statistical properties are related to time. Or it could be the fact that it's known that lung structure is fractal. Is it because of that, then that the flows that are coming out of the lungs therefore are also fractal? This is all speculation, and no one knows why. Also, and as I said, it becomes very dry until you then get to the point where you measure this slope, and then you find that it's related to treatment. If you so my supervisor back in Switzerland measured these slopes in asthmatic patients over a 6-month period when these patients were not taking any drugs, not taking regular asthma drugs. And then there were 6-month measurements again where the patients were taking a certain type of short-acting drug, and in another 6 months these patients were taking long-acting asthma drug, and found that these slopes actually changed depending on what treatment you were on. And so that's quite tantalizing, and that's why some people are quite interested in the potential implications of measuring this sort of slopes. That maybe the structure of how your lung function changes over time could be related to clinical measures. I've also found that if you measure these slopes during a period when the patients are not having any treatment, it can actually predict how they behave or what their response to treatment is later on. And so prediction is it's almost like a holy grail in medicine, as you can imagine. If you can predict when someone is going to behave, how someone is going to behave, then you can intervene ahead of time to try and stem whatever it is that's going to cause them to go badly. So exacerbations is something that people are very keen on predicting, and what they are is basically when you have asthma, people with asthma often, for whatever reason, suddenly experience a worsening of their symptoms and of their lung function. So if you're measuring their peak flow or their FEV1, they have the potential to just suddenly drop, and they stay that way for, say, 2 weeks. They sometimes get hospitalized, and there's still no good way to predict when an exacerbation would occur. So one of the applications of looking at patterns in lung function on a day-to-day basis is this. So in this study, for instance, we looked at peak flow again, plotted over months, and you take a certain amount of observation period, in this case over a period of a couple of months, and you can calculate the fractal properties that I was talking about, as well as other statistical properties, to try and characterize, to try and say, okay, this is the baseline for that person. And with that knowledge, you can try and calculate the likelihood of an exacerbation occurring. I'll probably not go into details today again, but if we define an exacerbation as a drop in the peak flow of less than 80% of predicted for that person, then the method that we came up with based on these patterns was actually quite well predictive of actual events that the patients then occur. This is all retrospective analysis. We looked at the time window, and then we compared it to data afterwards. But there's a very close relationship, a nonlinear one, but a very close relationship between the probability value that we calculate and the actual number of peak flow falls in these patients. So that was quite exciting. But that's where it's at the moment. There's nothing that there's no work at the moment trying to incorporate this into day-to-day monitoring, which would be the next stage. So how to apply? Well, at the moment here at the Woolcott, what I'm trying to look at is to see whether these methods could be applied to other diseases, and that's important because you want to know whether something is specific to asthma, or whether it's a feature of lung disease in general, or it could be that it's just random. So you need to validate that before that happens. No one knows what natural variability in health looks like, and so I'd like to spend some time and resources in trying to measure these variabilities in healthy people to see if you can see these patterns as well. And also, I'm also looking at trying to tweak the lungs in different ways, giving them bronchoconstrictors, giving them bronchodilators, making people take a deep breath, and seeing how that would change the patterns of their variability. And this would also be a matter of minutes as well as a matter of days and months. But as I said before, no one has really taken the next step of seeing how useful is this in day-to-day clinical monitoring. A big thing at the moment people like to talk about are asthma apps. So people like to, apparently, I say apparently because I'm not a big app person, to my shame, but there exist apps where people can punch in day-to-day what their symptoms are like and get a measure of how well they're doing. And so I don't see why a lung function measure could not be incorporated into that. And then you can calculate this probability or characterize the patterns using this technique. So that's just throwing some ideas up in the air and seeing where that lands. And another thing that I'd like to try and apply these methods to is the area of sleep medicine. Now, sleep medicine is sort of like a subset of respiratory medicine, or on a par with it, but it depends on who you're talking to. But basically, you may have heard of diseases like obstructive sleep apnea. These are sleep disorders which actually do represent a big burden on healthcare in Australia. And to study these diseases, people conduct sleep studies. Has anyone ever done or heard of a sleep study? Yeah? Alistair, okay. You know everything. But in a sleep study, you basically get someone to come in and stay overnight in a lab, and they hook up loads of electrodes on you. So you've got a typical sleep study, they vary a little bit. It lasts for 8 hours overnight, as I say, and you get electroencephalogram, so they measure your brainwave pattern. Glued on, thank you. You've done one yourself, have you? Oh, that sounds like fun. I haven't actually done one, but they measure airflow, and I'll talk a little bit more about that because I'm a respiratory physiologist. I like to talk about flow. They measure leg movements as well, and also eyeball movements. They measure cardiac, your electrocardiogram, and your oxygen saturation statistics, and also your chest and abdomen movements. So from my point of view, coming with what I knew about time series analyses of respiratory data, to me this is like a gold mine, because you've got 8 hours of not just respiratory but other data as well. So surely you can make sense of that information, find patterns in that, and somehow relate that to disease. And the other reason why, and I've since found out, so I'm new to sleep medicine, as you probably deduce, and one of the things I found out talking to sleep physicians is that the key gold standard of trying to work out sleep disorders or diagnose sleep disorders is basically just counting how many times someone has apnea, or what an apnea is when someone stops breathing. Counting how often that happens, counting how often someone just sort of reaches apnea but not quite, and then there's debate over how to quantify that as well, and they take the ratio of that, and that's their gold standard, and that's based on a pool of a small sample size of data, number of subjects, and that's widely applicable today. So you must be able to do better than that, and that's what I'm hoping to see whether it's... So it's a very speculative project, very early stages. There are some people who are also looking at it, but I'm coming at it from the point of view of respiratory data. So I'll spend one slide, no, maybe two, talking about respiratory measurement in sleep, and you might already be familiar with these. But traditionally, or from the days of yore, because in sleep you don't really care about what flows look like per se, you really just care about stopping breathing that stops. You have a very imprecise measure of flow, and this is done by thermistors. So you attach something that measures temperature fluctuations during breathing. The temperature fluctuations when you breathe in, the temperature of your breath is lower than when you breathe out, because the air that you breathe out is humidified and warm. It is warmed by your body core temperature. But the problem with that is that and you use a thermistor, because you must have done thermistors as part of your course. I was just nodding, so I'm hoping you're all on the ball. The differences in temperature would result in an electrical signal that you can measure, and which is hopefully related to the flow. But the problem with the thermistor is that it's non-linearly related to flow, so the trace that you get roughly mimics flow, but isn't exactly like it. So here's the relationship between flow and the signal that you get from the thermistor. So as you can see, you have a plateau here, and I'll show you what the implication of that is later. But more recent measures of airflow is the nasal cannula pressure, which is basically just a pressure transducer. So you've got, it's very crude, it's really just nasal prongs in here, and then you've got a pressure that's attached to a pressure transducer, and that is or can be made to be linearly related to flow by an equation. So, as I said, the primary goal in sleep medicine is to detect apnea and sort of apnea, so things that don't quite get to apnea but are almost there. And the nasal pressure is known to be much better at detecting half apneas or sort of apneas compared to apnea. So here you can see that with a thermistor, it looks like nothing has happened, because it's not very sensitive to the flow, but actual pattern of flow. But with a nasal prong, you can see that these flows here are much smaller compared to these larger flows here. So something's clearly happening there. And this is just another graph showing the relationship between, if you try and take peak inspiratory flow with a thermistor, you get no relationship between the pneumotac, which is, as you recall, the gold standard, whereas with nasal cannula, you get a pretty good measurement. And the reason why this is important for me is because most of the pattern analyses, time series analyses have been applied to tidal volumes, and so with sleep medicine you're going to have to look at an alternative measure if you don't have something that measures flow accurately. So a way around it might be to look at the inter-breath intervals, so look at the time between peaks, and there have been people who show that there's a pattern also in the distribution of the intervals over time. So current projects of interest, if you're looking for a project, here are some ideas, and you're very welcome also to pitch your own, and someone has already during the break, which is quite exciting. But to summarize, that what I'm interested in basically is back to looking at the patterns in lung function over time. A lot of the work that I've done is related to peak expiratory flow, but now here at the Woolcock, they measure impedance a lot, and I'd like to look at impedance and changes of that over time and seeing whether the same sort of patterns can be measured in impedance over time, and then see if this is useful for the prediction of exacerbations and whether you can incorporate that into day-to-day monitoring at home. And sleep medicine, can we use breathing variability to, for instance, deduce sleep stages? At the moment, sleep stages are quite crucial to a sleep study because people basically only certain parts of stages you can only make sense of certain parts of sleep, and not during REM sleep, for instance. But to do that, you need brainwave measurements. So can you do that just from a respiratory signal? And there's some evidence to suggest that that's possible. Can you use it to